Look at this one. Huh. Child didn't quite make it. Rachitic rosary. This is in reference to osteochondral junction. You see that? Once again, make sure you get a proper history because you might see this in vitamin C as well. This is what it looks like on X-ray. Osteochondral junction, which is expanding. What kind of bone is that? Mineralized or unmineralized? Unmineralized. Unmineralized matrix, right? All right, so now take a look at this. Poorly mineralized epiphyseal center. That makes sense. Why? Because you don't have the calcium and phosphate. Don't memorize this. Take a look at this. It should be able to explain what's going on. Irregular widened epiphyseal plates. We'll see this in a second. Increase. What's epiphyseal plate also known as? The metaphysis. Is there cartilage? Yes, there's cartilage there. Increase in distance between the end of the shaft. Take a look at this. Here's the epiphysis. And here's the metaphysis. Increased distance. Coarse trabeculation. With vitamin D deficiency, it's coarse trabeculation versus what you will see in, what's trabeculation? It's basically it should be the organized growth of the bone in the diaphysis. And if that is not taking place properly, why is it not taking place properly? Because you have excess deposition of unmineralized bone. Well, I'll show you what coarse means versus ground glass trabeculation. And then here, I'll take you through this. This is what a normal line should look like. The epiphyseal plate, this is normal. See that? Nice little line right there. Might not necessarily be linear, but point being is it's narrow. Here, the overgrowth of the epiphyseal plate. Why? Because what are you depositing? Unmineralized osteoid. Take a look at this. This is also, once again, this right here is the increase. See this versus that? That should be obvious as to how much overgrowth there is. So in rickets, the chondrocytes proliferate. What do chondrocytes produce? Cartilage. Do not mature and degenerate. Why? Because mineralization hasn't taken place. Thus, there is cartilage retention and unmineralized osteoid matrix covering. Do you understand why you need mineralization? Do you understand why it's not taking place? Do you understand why you're having these signs and symptoms? All right, so here. I want to be out with you guys so much, I need to keep coming back to it. All right, here's the epiphysis. Here's epiphyseal plate. What kind of cells are those? The cartilage? Yes. And here's the diaphysis, growth. Let's take a look at this. Let's take the epiphyseal plate, the EP, and magnify it. If you're going to have any type of proliferation, you need to have mitosis. You need to have enlargement. And this is the key point. This is normal once again. This is degeneration. Degeneration will only take place if you have mineralization. If you don't have the mineralization, that degeneration does not take place. Why? Because all of this is cartilage. And this is a cute little picture in which I just thought that, you know, you have a cute little baby as it goes through the circle of life. And then here, this is normal. This is normal. This is bone growth moving in that direction. So down here is a diaphysis. If it's rickets, it's unmineralized bone. See how coarse all this stuff is? This is what I mean by coarse trabeculation. It's not neat and organized that you would expect with normal bone. Okay, that's what's meant by coarse. So make sure that you understand. Once again, it's unmineralized osteoid. Zone of proliferation, zone of hypertrophy, and zone of ossification. Thank you. All right, so then let's go on to osteomalacia. All right, with the osteomalacia, and I'm going to spend too much time here, it's remodeling because at this point the bone is already formed. You had sufficient mineralization when you were a child. But the problem lies in the fact that you have remodeling issues. Because as you know, as you get older, your bones are being replaced, well, slowly being replaced. So that we have a problem with remodeling. You do not affect the contours because contours have already taken place. So therefore, you do not have the radial overgrowth. You do not have the bowing. You do not have the pectus, carinatum. And then here, please pay attention. Your bone, however, is still weak. It's remodeling, but still weak. And so therefore, this particular patient might be and is prone to fractures, known as a milkman syndrome. The femoral neck might be affected, or the shaft of the diaphysis. Why? Are you having mineralization or not? You're not having mineralization. The bone is weak. Remodeling is weak. Are you guys paying attention? Okay. Causes. The only thing that I'd like for you to look at here is if it's vitamin D deficiency, what do you think happens to your phosphate levels? Well, before I go there, what happens to your PTH levels? You have decreased calcium, increased PTH. What does the PTH do? What does it instruct the kidneys to do? To flush out the phosphate, and therefore you expect your phosphate to be low. Lo and behold, there you have it. Now, if it's renal disease, this is the next step, because this is where you might get confused. If it's renal disease, what enzyme isn't working? Alpha-1 hydroxylase. The alpha-1 hydroxylase isn't working. You don't have activated vitamin D. Your calcium levels are low. Your calcium levels are low. Do we agree? If your calcium levels are low, who is being triggered? PTH. Now, the PTH is going to go to the kidney and instruct it to do what? Can it do it? Can it do it? If you have renal problems, you have kidney issues, can you flush out the phosphate? Even though your PTH is increased and it's telling your kidneys to flush out that phosphate, is it going to do it? No, because your kidneys are dead. So now at this point, are you going to have hypophosphaturic? Or is it going to be hyperphosphaturic? Hypophosphaturic. Your kidneys aren't working. You can't flush out the phosphate. Take a look at that. Increase PTH. Calcium levels are extra high. But your kidneys aren't working. You can't flush out the phosphate. So what happens to your phosphate in your blood? So please make sure you know where you are. Hyperphosphatemic. Why is it hyperphosphatemic? Because your kidneys aren't working. Huge. Taking your boards and doing your question or whatnot. You're running out of time. And they tell you about the phosphate. Find out as to whether or not they're talking about the blood or if they're talking about the urine. All right. And if it's hyperphosphaturic, then you know it's what? Where's the problem? If it's hyperphosphaturic and you have increased PTH, the problem is in the kidney. It's secondary hyperparathyroidism. Secondary hyperparathyroidism. Because the kidneys are the ones that are causing increased PTH. Review that. I don't expect you to know that this very second. I'm not going to ask you point blank, but please make sure you understand that point. All right, so then here. Pseudofracture, osteomalacia. Here, take a look at that. It's radiolucent because this patient has osteomalacia, vitamin D deficiency. With treatment of vitamin D, take a look at that. Nice and bright, radiopaque, beautiful. All right, then here, quickly, this is osteomalacia. This is mineralized bone in green. This is osteomalacia. And therefore, you have what type of deposition? Unmineralized matrix, unmineralized osteoid. That's what that means. Normally, here's your mineralization, and you do have some osteoid, but look how thin that seam is. Okay, so be able to recognize or at least interpret as to what's going on. So here's increased osteoid because osteomalacia. Then down here, once again, you have mineralized bone. This is all osteoid. And then, of course, if you have destruction, how do you repair it? Heard the term fibrosis? Okay, that's what that is. I'm going to skip over renal osteodystrophy. We've covered this. You have decreased alpha-1 hydroxylase, decreased 125. It stimulates the PTH, but what happens to the amount of phosphate in your urine? Decreased, because your kidneys aren't working. So therefore, it's hypophosphaturic. If it's primary vitamin E deficiency, your phosphate in your urine would be what? Hyperphosphaturic, because your kidneys will be working. If that doesn't make sense at this very second, review it, please, because you need to understand it. Also, if it's renal osteodystrophy, your levels of phosphate are increased in your blood. But that PTH is doing what? It's absorbing calcium from your bone. And what did I say about mineralization? You need both calcium and phosphate. All right? Now you have that calcium, and you have increased levels of phosphate. Remember metastatic calcification versus dystrophic calcification? Metastatic calcification, what are your levels of calcium phosphate? High, super, super high. And they can deposit anywhere. That's metastatic calcification. Dystrophic is what? Calcium phosphate levels, CAP is normal. However, you have an injured structure, right? Review that. However, in this particular case, what I need you to know is that with renal osteodystrophy, it's going to be metastatic calcifications because you have increased phosphate and that calcium, there's enough calcium there, which it will deposit. Wow. That would have been entertaining. I'm going to skip over osteitis because I need to cover. I would like to go on to vitamin C in the last few minutes. I'm going on to vitamin C. And then Monday, if I have time, I'll cover this stuff. I need to go over vitamin C. Okay, quickly. This will be enough time. So I'm going to vitamin C. Water soluble. So all that was fat soluble. A and D was fat soluble. As far as water soluble, speak of vitamin C particularly. Here's James Lind, Vasco da Gama. Interesting enough, as he was traveling through around Africa, because quite a bit back then was the fact that they just did not come across citrus fruits. And so they suffer from quite a bit of deficiency. But anyway, all right. So now let's do some of the functioning of vitamin C. You see this in biochem, and I need you to understand this. Vitamin C is responsible for, it's a reducing agent. Okay. Now, what is it meant by reducing agent? Well, it'll take ferric. What's ferric? Is that iron 3 or iron 2? 2 plus. Yeah, ferric is iron 3 plus. If it's a reducing agent, it will take, but what's the active form of iron? Ferrous, 2 plus. You have the vitamin C, which is a reducing agent. It will reduce the iron 3 into iron 2 plus. It'll also, in general, it will also do that with copper. Don't forget that. These are things that you need to know. Things that enzymes in the biochemical pathway that will affect you on a pathological level. All right, it's a reducing agent. Now, something that you've seen, maybe not necessarily remembered, but seen, but now at this point, you do need to remember. Collagen synthesis. Collagen synthesis. Anywhere else, it begins in the nucleus. Okay, let's go through this. It's on the very top, on your right side. Remember exons and introns, nucleus. And then you go into your RER, rough endoplasmic reticulum. If it's rough endoplasmic reticulum, are you going to produce proteins? Yeah, that's what RER means, because you have the ribosomes. Remember transcription? The mRNA goes into the ribosomes, and then it's going to go into the ER so that you can translate your protein. What protein are we producing? Collagen. We're producing collagen. We're not quite there yet, because there are certain residues that need to be hydroxylated, specifically proline and lysine. Once again, in order to complete your collagen synthesis in your endoplasmic reticulum, you have hydroxylation of your proline and your lysine. If you do that, you will properly form your triple helix. If you form your triple helix properly, you have a strong band of collagen. And what the heck is collagen for? How about everything? One, we'll see this. I'll show you a graph real quick. Collagen type 1, bone, 1, bone. 2, cartilage. 3, reticular. 4 is the floor or the base membrane. Collagen types 1, 2, 3, and 4. I have a little graph, so don't write it down or anything.